No allergies. Admitted yesterday, whatever that was, don't remember the date, the 17th. And she is MICU 2 service. Past medical history of CAD, hypertension, COPD, and diabetes type 2. So patient presented to the ED via EMS after being found unresponsive at a family function. Patient experienced 2 witness rounds of emesis with suspected aspiration. Vital signs and blood glucose were obtained in field and were as follows. So respiratory of 35, tachypneic, heart rate of 105, slightly tachycardic, BP of 96/50, so low normal with a MAP of 65. SpO2 was 90%. Blood glucose was obtained and it was 450. Patient's family states that she's been compliant with her insulin since she was diagnosed with diabetes, but patient's family also states that she's been recovering from a viral illness for the past 2 weeks. Upon arrival to the ED, patient was severely lethargic with an SpO2 of 88%. A CBC, BMP, and VBG were all sent off, but we were awaiting the results still. Patient was started on an insulin drip for management of suspected DKA, and then she was also placed on high-flow nasal cannula and sent here. Her assessment, she is a little bit lethargic. She's like a 3, 4, 4. She like answers her orientation questions, but she's very sleepy. Only arouses to like verbal stimulation, that kind of thing, okay? Pupils are reactive, 2 to 3, equal reactive, no pain for me. She is on high flow nasal cannula, which is what you've heard and this is. So why would we put somebody on a high flow nasal cannula and not a normal nasal cannula?
Because it's like, it puts like more pressure, like forces it.
Yeah, it provides more percentage of O2 with more liters of oxygen per milliliter. So how high does your nasal cannula go? How many liters can you give per nasal cannula?
Like 6.
6. So after we reach that threshold, we'll go to like a high flow nasal cannula. And then after that, we could go to like BiPAP if we needed some like PEEP in there to like keep that alveoli open. So that's kind of like the non-invasive ventilation options. Okay, so she's at high flow right now. She's been satting anywhere from like 88 to 90%. Service is aware, they're okay with that as long as she doesn't dip down anymore. She's been right about there. Lung sounds very coarse, diminished. She's afebrile, she's tachypneic in the 110s to 120s. Not really any ectopy for me, just like I said, sinus tach. Abdomen soft around tender, positive bowel sounds, last bowel movement prior to admission. She's NPO currently. She voids in the bedpan, does fine with that. And like I said, we're awaiting the CBC, BNP, and BPT to come back from the lab. Any questions on her?
I don't think so.
Okay, so a big thing in report, whether you're coming on or going off, is that you have all the information you need to safely care for your patients for the day. So that is a two-way street. So it's my responsibility to give you all the information that you need to be able to adequately care for this patient, but it's also your responsibility to fill in any gaps that I might have missed, okay?
I actually thought of a question.
Yeah.
How does she get up?
We haven't gotten her up yet. She's been too lethargic, dizzy. I just don't want any calls, so we haven't gotten her up.
Okay. Do we see diet at all?
Yeah, she's NPO.
Oh, NPO.
NPO.
Next up, you are the instructor first, this is where you're starting.
What you guys got? We'll head over next door. Okay, so this is John Edward Smith. He's a 55-year-old male, full code, no ISO, allergies to penicillin and sulfas. His service is cardiology 2, cardiac surgery, past medical of CAD, hypertension, COPD. He had a STEMI back in February of 2015. His diabetes type 2, sleep apnea, non-compliant with BiPAP at home. and anxiety. So patient was at a restaurant and presented with complaints of sudden crushing chest pain radiating to back and left arm, accompanied by nausea and shortness of breath. EMS was called and arrived to the scene around 30 minutes later. They performed an EKG in the field that showed marked ST segment elevation. EMS administered 325 of aspirin and came here. He arrived to the ED probably, like I said, about 30 minutes later, was assessed with confirmation of an inferior MI with right ventricular involvement. So that's an inferior MI with right ventricular involvement, and his initial troponin was 150,000. So the patient was taken directly to the cath lab with a stent placed to the RCA. He came out fine, no drips, no real major issues. He's just here for further monitoring in the ICU, in the CVICU. Any questions on story or plan? Hopefully he'll be going home soon.
So you said they gave him aspirin and
In the field,
did
yeah.
he get nitro or anything?
Not that I'm aware of, I don't know for sure.
Okay. How does he void?
He uses the urinal.
Okay.
So, assessment-wise, he's a 4.65, pupils equal round reactive, 2 to 3 millimeters, no pain, room air, SATI 95 and greater, clear diminished lung sound is afebrile. He's been normal sinus in like the 70s to 80s. He has had a lot of ectopy, a lot of PVCs, occasional bigeminy, but nothing sustained. Abdomen, soft round, non-tender, positive bowel sounds. Last bowel movement was also prior to admission. He's NPO currently. They want to make sure he doesn't have any chest pain to make sure he doesn't need to go back to the cath lab for any reason. Told you he voids in the urinal. We did send off his labs. His MAG was 1.3 and his potassium was 3.4, so we're waiting for the replacements to come up from pharmacy. Okay. Any questions?
So potassium 3.4.
3.4, yeah.
Okay.
Yeah, pretty low, and his mag was like a little bit low too. So like I said, we ordered him some replacements, and they should be up soon.
Okay.
So you guys can start over here or wherever you want, and then you can just assess and. But I mean, I don't know if there's any in here, but. Do you guys know how to call back if you need anything?
No.
This, and control 3 right there, okay?
Okay.
That's how you call back.
It's easy.
Yep, easy.
Thank you. Courtney's in another room too.
And then for positive representation, we describe
Alright, good morning, Miss Brown. My name is Savannah and this is Hannah and Grace. We're going to be working with you today. We just got report. Could you go ahead and tell me your name and birthday?
Sarah Brown. I'm a Valentine. 1956.
Alright, I see that. Here, do you mind if we sit you up a little bit?
No, I think that's real good.
Okay. That's the wrong button. Maybe sit up maybe just a little bit. This will help with your breathing too, okay? Alright. So, we're just going to check you out and do a quick assessment. How's that sound?
As long as your hands are warm.
As long as your hands are warm.
Oh, sorry. They're not going to be too warm. Alright. Let me check your pulse.
what is going to be your evaluation?
Just like that.
So, we already have an airline.
Let's pretend that she grabs.
Breath down.
Yeah, we have to grab our fingers.
Ongoing bleeding, so you have to.
Are you having any concerns today?
The first thing is you take out.
No, I'm just real sleepy.
Just tired? Did you get any rest last night?
We're in the hospital setting, so.
Oh, I think so.
Oh, you did? That's good. Okay.
Yeah, addressing the
Um,
current bleeding, hemostasis.
Have you had any kind of
Can you describe
confusion, do you think?
for the patient who requires a tourniquet, he has one.
And could you tell me where you are right now?
My daughter said I was.
Oh, she said you were?
Can you tell us where you
I
are right
think that's
now?
what she said.
Okay.
The Steps Hospital.
Yes. Do you know what you're doing here? Like why you're here?
I don't remember, something about sugars maybe.
And you have to nurse.
Okay, and then who's the president right now?
On the other arm, and they're unable to.
What'd you say?
Who's the president?
Oh, that newer one, Biden.
Okay,
Okay.
yeah, good job. All right, so, um,
I'm just gonna palpate your stomach and tell me if there's any tenderness, okay?
All right. Everything feels all right.
all right, and now we're just gonna give you a listen, okay? So we'll listen to your heart first, and then we'll give your lungs a listen.
Alright.
Have you been having any shortness of breath?
Go under your gown.
Maybe a little.
A little bit, okay.
Have you had any pain recently?
Not that I remember.
Okay. So on a scale of 0 to 10, what would you rate it?
Oh, just some aches and pains, like a 2 at times maybe.
Okay. And where's the pain located at?
Right now, just from laying down.
So it's just everywhere?
Yeah, just from being in this bed, I think.
Okay.
All right, Miss Brown, we're gonna check on your neighbor next door, but we'll be right back.
Alright, I'm gonna take a nap.
Okay, you just give us a call if you need anything.
This is Grace.
All right, he's doing too. He's not breathing either. Oh, he's not? No. Is there a pulse? Is it too high? Apnea? Can't feel a pulse. All right. All right, then I guess we start.
I don't know that there is a code button.
Okay, I have the crash cart here too. Let me turn this on.
Code blue, sim 4.
Yeah.
Code blue,
Okay.
sim 4. Code blue, sim 4.
Okay.
What's going on here?
Okay, we have Mr. Smith here, full code. He's
Oh my God,
Do
why
we have a
haven't chest
pulse?
compression been started? What is this? What is this on the monitor here? What is it? Tell me what it is.
Is it, what is it? Tamponade? What is that?
Torsades.
Torsades.
Yeah, so this is polymorphic VTAC.
Okay.
Was there a pulse?
We
No,
didn't feel
not
one,
that
but
we
we also
Okay.
didn't feel one on the other lady, so I
Okay.
wasn't sure.
So, torsades, polymorphic VTAC, no pulse. What's next step?
Compression.
Yeah, get on the
Yeah.
chest. So you want to drop the bed as low as it can go.
Yes.
Yep. And go ahead and start compression.
Alright,
So-
so you wanna start?
Yep, start compression. A little higher.
Right here?
Yeah, a little higher.
Alright, right now it's 225.
Perfect. So you're kind of going through the roles. What roles do we need to have in this situation?
Someone documenting and keeping track.
Yep, so a recorder, I'll be your
Yep.
recorder. You have somebody on the chest, you have somebody on bag, on oxygen, and you have somebody on
I
life
just turned it
pack
on, yep.
and the meds, okay? And then you have your provider here to help run the code. So whenever you see, so for ACLS, continuous,
Just continue
yep,
it?
continuous compression. So this is a
Okay.
little bit different than
Okay.
BLS. So you're in the hospital, we're going to go for ACLS.
Okay.
All right, and then Dr. Aaron will kind of describe the process or like the what happens in ACLS, okay?
Alright, Hannah, you still good?
Yeah.
Can we hook up the defibrillator?
Yep, so with the life packs, you have 2 pads, and they'll look a little bit different than this obviously in real life. You can stop compression and we'll do this.
Okay.
We'll do this in like a stop-start kind of situation so you guys
Okay.
can like see what's going on, okay?
Like actually.
So these are what your pads are, okay? But in real life they'll actually be like more of a
Like a sticker.
like actually like a sticker. I also hate when people lock the code card in real life. That drives me insane because you'll tip it over. I've done it. So okay, so they'll tell you exactly where to go. You put one at the top there, one at the top here. If your patient is in a shockable rhythm, a pulseless shockable rhythm, you really only need these two pads. If you need to pace somebody though, you have to put on these.
Oh,
But like
okay.
the first, like you should put on all of them, but like your main priority
Just to get
are
this.
these two.
Okay.
Because these two pads in real life can like monitor your rhythm and do all that kind of stuff. So those ones go on first, and then you can put on your secondary leads, and they just go through. You put this on the left lower, the left arm, and the right arm. Okay? So you want to put those on.
Yeah.
So,
It's like where the snaps are.
yep.
Yeah.
Yep. So that's like the next big step. So
So
left
left
arm,
arm.
left lower, and then this is your right arm.
So just
Yeah.
Hey, Dr. Aaron.
Alright, so we're doing compressions. We're in a shockable rhythm.
Mm-hmm.
So we're turning it up all the way.
Turn it up all the way.
Yeah, turn it on, go to
So
like
he's talking about like if we want to shock this patient
Yeah.
because it's a shockable rhythm, you would select your joules. So you start off with 100 and you can change your current by using this button here. So you will select your current, and then whenever they're ready to deliver the shock, you hit charge, it will charge. You continue compressions while this is charging,
Yeah.
and then we'll go through it. But so you want to be doing this, and then you also want to be taking stock of what medications you have. So in the top cart or the top drawer of your code cart, you want to unlock it first, because I also see people sit around like bang it out and it doesn't work like that. You have to unlock it. You pull this out, and then all the medications that you would need in a code are in this top drawer. So you have epi, calcium, you have bicarb up here, you have dextrose, you have amio here. So you have everything that you should need in this top drawer. So to put these together, you will pop off that and pop off that, and it screws on like this, and then you take off your little top here, and then it squirts out, okay?
Okay.
And that's the same with all of these in this drawer.
Gotcha.
All right. So, Aaron, when would we want to give epi versus other code drugs?
so after the shock, then you can also give epi. Epi is every like 3 to 5 minutes. Typically you just alternate between epi and like an antiarrhythmic, and you give the meds like in between the shock type things.
So
So it ends up being like every 4 minutes epi, every 4 minutes the antiarrhythmic, but they're like.
So what would be an example of an antiarrhythmic? We talked about one a couple weeks ago in class with VTAC, and then we also have one in this top drawer that we could use.
Is it the calcium?
So it would be your amiodarone.
Okay.
And then the other one would be, say, lidocaine. So if you have somebody who's in VTAC but maintains a pulse, your like a first line go-to would be your lidocaine. So you would give them a lidocaine bolus and then start a drip. So for ACLS protocol with a shockable rhythm, we would alternate, like Aaron said, between epi, and then your starting dose of amio would be 300. So there's 150 per vial, so you drop 2 vials and give them 100 or 300 milligrams of amio.
Okay.
So let's practice shocking. Okay, so we're doing compressions. We've selected what we want to, what our initial shock's going to be. We say charge. It charges to the joules, and this, you're still doing compressions during this. And at this time, if I was the one running this, I would say clear, and I don't just say it. I look head to toe. So I would say you need to back off the bed. You need to back away. Aaron, everybody back away. Clear. Preparing for shock. Shock delivered. Resume compressions. Okay? So that's how this would work. So can we get, I would like them to throw him into another rhythm so we can talk about it. Can you have them throw him into sinus breathing?
Yeah.
So we have run a couple compressions, given some epi and amiodarone, and we've delivered a shock, and he's converted soon to sinus Brady.
Okay.
So with this patient, why do you think that he would, so whenever we were developing this case scenario, I discussed with the other instructors that a more likely scenario for this patient would be that he would go bradycardic and require like transvenous pacing or like TV pacer or something like that. Why do you think this patient would go bradycardic? What about his history would say,
He's got a stent placed.
where was that stent placed?
Right.
Coronary artery?
Yeah.
Because he had what kind of MI?
An inferior.
Mm-hmm.
I
So
wrote it down.
inferior MI.
Reason.
Yeah, he had an inferior MI with right ventricular involvement. So that's what your RCA feeds. What else is located there that your RCA would feed that would, if ischemia developed, would cause bradycardia?
I can't think of it. Like the heart's pacer.
Yeah. So which are the what kind of nodes? And AV nodes. Yep. So those are located there. So in ischemic events, those could become damaged and they could go bradycardic and have bradyarrhythmias. So whenever you guys are each doing your care plans and pathophys, you guys can talk about that. And also you can talk about his torsades. So why do you think that he went into torsades?
It's like when the heart just starts freaking out because his notes weren't working.
So what do you think like led up to that? So what did I give you in a report that that would be like, oh, this is probably a good indicator why he went into torsades?
Do you know the treatment of torsades?
I don't know. I just know it's really bad. One time someone thought my patient was in torsades and they all freaked out. She was brushing her teeth.
So we talked a little bit about it in our lecture, but it would be a low magnesium level.
Okay.
So a mag of 1.3, that's low. So this patient would need some mag. And as Aaron said, that's something that in this whole ACLS process, we would want to give. Okay, so we would probably give you can give 2 to 3 grams of push dose mag in code situations like that. But just to keep that in mind, that was probably a precursor to this.
Did you want to talk about the nitro right now?
Yes, I did. So you asked if he had gotten, somebody asked if he had gotten nitro. So why would this patient not get nitro? This kind of MI in particular. This is kind of just I wouldn't normally talk about this, but I felt that was interesting that you asked and I wanted to elaborate on it. You don't have to know.
I don't know.
No, I don't know this.
For it.
Sure. So the right ventricle is preload dependent. Does that make sense?
Yeah.
So it has to be, in order to help with its contraction, it needs to be stretched out first. And nitro is a vasodilator. And so because you've given nitro, then that decreases preload. So you're actually worsening it.
Yeah, they'll be profound.
If it's a right-sided.
Yeah, they'll be profoundly hypotensive. So if somebody has a right-sided MI, we do not give nitro. Big no-go. Okay, so this patient is back and relatively stable. He has a rhythm here, but we have no O2 sat and no art line monitor. So this is again more than you really would need to know, but what would I be worried about here? We have a rhythm, but we don't have an O2 sat, we don't have a blood pressure.
Well, you can't shock him again because he has a rhythm. You keep bagging him or put him.
Yeah, so you're right that he doesn't, you can't shock this. This is what we would be called PEA, a pulseless electrical activity. So he has a rhythm, but he's pulseless. He's not getting any cardiac output. So we would continue ACLS here. We would continue doing compressions and pushes of epi and amio, those kind of things until we got pulse back. Sound good?
Yep.
What questions do you guys have from this little stop-start debrief?
So it's as soon as he starts in torsades, you just start.
Yeah, well, you
compressions?
see it, you say, oh, what's happening here? You check a pulse, you should check a pulse first, there's no pulse, chest.
Mhm.
And then you would obviously call a code, get people in there, delineate roles, your provider would be there, and then you would start through the ACLS algorithm. So depending on what rhythm you have here, if it's a pulseless, shockable rhythm, you would go down one algorithm. If it's PEA, you would go down another algorithm. If it's bradycardia, you would go down another algorithm. And you guys will be taking the ACLS course, so we won't get too like heavy into that, but this was just kind of like a precursor, so you could like see and kind of understand the roles of a code and what is expected at the very basic level.
Yeah.
Any other questions?
Just like, how would you, so like, you know how patients just have nitro, like how, so like if he would have just taken it
Yeah.
because he has a history of heart attack,
Yeah.
he would have made himself way worse, and there's no way of knowing that.
Yeah, not from his perspective.
Yeah.
I mean, because he does have a history of like MI, cardiac
So
disease.
he probably have it.
So he probably does, depending on what kind of MI that was.
Mhm.
He might have nitro at home to relieve any sort of like angina or anything like that. But yeah, so that's kind of one of those things that's like hard for me to control as a healthcare provider. But that is something that we do need to know, especially as a CVICU nurse. If I have a STEMI coming in, I need to know exactly what kind of STEMI that is. So
That's why they do
If
that,
I-
like EKG in the field.
yeah. So I need to know like what kind of meds I need to have in the room. So if I need to have a nitro drip set up, I can have it. Deal? So you're not done yet. This was just a stop-start. So you guys can still continue to assess your patients, go next door since we've been in here for a while, see what's up with her, and then we'll go from there, okay?
Okay. So
Sounds
we're
good.
like pretending like he's still getting coded.
No, he's back and like alive. and
Oh,
happy.
okay.
You
Yeah,
saved
you saved him. You did great. Beautiful
Alright.
job.
Should we unplug him?
Talk more about like how to do this, like in class. Like,
Yeah, and that's the
Like-
purpose of this course, right? Because I want you guys to be able to see things that you won't really see.
That's like, I watch it happen, but it goes so fast, I don't know.
Yeah,
It's like I've seen this happen, but I'm always the runner.
And it's so
Like,
fast.
stuck in the
Yeah.
hallway.
Yeah,
Actually
exactly.
do it.
Yeah, absolutely. So I'm gonna turn this off just so it doesn't keep beeping.
Okay.
Hello? And you have a call next door that you can get to. So holler at us if you need us.
Alright. Hi, this is Savannah.
Yes.
Okay, great. What are they? You feeling okay?
She's on 81. Show me
Okay,
like.
hold on. So you said bicarb 20, what was the CO2 and PO2? For both. Okay, thank you. Can you take some deep breaths for me? Are you not feeling so good?
No, she's
Okay.
81%.
pH is 7.25, CO2 50, PO2 50, bicarb 20. So it's because of her, maybe we should call the provider. Yeah.
Yes.
See if we can get it stopped. What's her last name? Brown? Miss Brown, are you able to take a deep breath through your nose, out your mouth? Hi, this is Savannah.
Miss Brown, I need you to try to do that for me,
Kara
okay?
Brown. I'm calling because we just received some critical labs, and I was wondering if her insulin might need to be changed, because she, right now it's running at
Yes, so.
5 units an hour. 5 units an
We're
hour.
gonna do in this scenario, we're just gonna select one of them, and so we'll just.
pH 7.25, CO2 50, PO2 50, bicarb 20. She's very lethargic. She's not really speaking to us. She's kind of out of it. She's not really oriented, not really talking. Her O2 is 82 on the high flow, and she's satting, well, 81 now. Her respiratory rate is 12.
Prior to central access.
41. It's 41.
There we go.
Yeah, if you just want to come in and assess her.
So.
Just taking short, deep breaths.
Okay, thank you. I was like, it's 12, and he's like, hold on 1 second. Yeah. After you said that, we're just like, okay, Miss Brown, get her way up. Let's stitch it up a little bit.
No,
Yeah.
it wasn't. Always better.
Can you talk to me and tell me what's going on? Can we crank the oxygen up? Put it, oh, I guess it's like not really. Put it like all the way up. All right, Miss Brown. We're here with you. Can you talk to me and tell me your name? Okay, maybe we need to get like a non-rebreather or like something like that. Can you talk to me? Okay, so we need
Squeeze my
suction.
finger.
Hold on. There is no suction. Okay, pretend like
Okay. Hold on, I'm just gonna suction around in your mouth. Do you guys want to listen to her lungs sound? Do you feel like you need to spit something up? Oh, choose supplies. Thank you. All right, dear, we're gonna set you up with this.
Hey guys, what is happening here?
Okay, so almost definitely DKA, and I know that patients have to like breathe that off, like when their bicarb is that high. It sounds like her lung sounds are getting worse.
Yeah, it sounds like she can't really.
We
put
don't
in
have
her-
suction in the room.
Yeah, that sounds like a tube to me.
Yeah.
For sure. So what, did we have any like gases or labs or anything
Yeah,
like
they're
that?
written down on my paper.
Okay, tell me what they are.
pH is 7.25, CO2 50, PO2 50, and bicarb 20.
Okay, so I'm kind of new here. What does that mean?
So it means she's probably in DKA.
It means that she's probably very acidotic.
Yes.
Very acidotic. So there are a couple of things that are compounding this acidosis. A, she is in DK, but she's also a possible ARDS patient, right? So she has a couple of things that are like compounding here for her to be very acidotic. So her CO2 is also what? 50. So very hypercapnic. What would we see with a patient who's hypercapnic?
Like air hungry, gasping for breath.
Like
High respiratory rate.
unconscious,
Yeah.
maybe a little goofy if they're used to it, but usually it's not like chronic. So, so what do you think would be a good next step here?
We should get a sugar, and also we're gonna put this on her breather.
Okay, perfect. So from a nursing standpoint, safety of the room, right? So we want to get oxygen in here, we want suction, we
put her
sat her
right
up. Yep,
Yeah.
perfect. From MD standpoint, what do you think are next steps here? Intubation, and why intubation?
So, because of her like alertness. Have you ever heard the GCS less than 8 thing? You know that?
We talk about GCS.
Okay, I mean it's not like I wouldn't expect to like figure out a whole GCS right now, but just like patients that are like headed that way towards unconsciousness, their GCS is dropping, they can't like protect an airway, so they'll need intubated. The saying is like GCS less than 8 intubated.
All right, so the plan is to intubate. So next step from nursing perspective, again, is safety. So we want to have the intubation kit in the room for the provider. You don't have to have like a code card necessarily, but you do need to have some emergency drugs on hand if you have to, if something were to go down, if we popped the pneumo, if we went into like a tension area, you just never know. People respond differently to intubation. So just set yourself up to be able to handle anything, okay? And then also, whenever we intubate a patient, we will sedate and paralyze them.
Yeah. I was gonna ask if there are restraints in there.
Not in here.
I always
but
am the person who runs the restraints.
there are not any in here.
Okay.
But yeah, so you will probably need to restrain this patient after they start waking up from being paralyzed. But I'll let Aaron talk a little bit about paralytics and sedation and why we use them.
So, do you know some of the paralytics?
So like 16.
Yep, so succinylcholine, that's one, and then rocuronium is another one. Those two are really commonly used for intubation. So commonly you use a paralytic because like you're shoving a tube down their throat, right? And that's like there are muscles all through there, and when you're irritating them like that, they can like spasm. And so you need that all to be paralyzed, so you can just like slide the tube down. And it also doesn't help that like they can't move either, so like fight it and whatever. You also sedate them. You want to sedate them first because you don't want to be paralyzed and still awake, right, feeling that. So do you know some things you can use to sedate them? Yep, you got it. Propofol is one. We got ketamine, you can use that. You can use etomidate. Those are really common.
Accommodate's actually in the code. That's the only one of the sedatives that's actually here. It's just a real world experience. Everything else you have to get from the med room. So in the state of West Virginia, it is not in the bedside nurse's scope to push certain sedatives and paralytics. So I am not allowed to push ketamine, propofol, or anything like that, okay? So that goes to the, Doesn't happen. I can't say what happens in real practice, but in the state of West Virginia, per your license, you are not allowed to push certain medications, okay? That goes to the provider or mid-level nurse practitioner, whoever's there, okay? In your knowledge. So, what 2 drugs would you like, and how much?
I'll do propofol, I guess. So propofol is dosed like 1 to 2 units per kid, I believe. So, and she's, how much does she weigh?
Oh, she weighs like 95 kgs.
95 kgs. Okay. So like 150 of propofol. How much is in that?
150. You want to do 150 per? You want to do like per kit or what? Do you want to do
Total.
Oh.
Is it?
Yeah. So I mean, like it's like. So normally we would do like maybe like 30 of propofol to start, see what happens, or maybe like or like 30 of ketamine, like 30 of ketamine is like 30 of ketamine. See how she does with all that, and then we would go from there. So I'll let you guys go ahead and pull these up. I'm going to give you each. So you can pull these up. You can't give them.
Yeah. Would we still like call a code on this or?
This would be more like a rapid response. I wouldn't hit a code bell for this. I would call the provider. This is like a respiratory code. I mean, I shouldn't say don't hit the code bell.
I know.
I
feel like half the time they call the code and half the time
in the ICU, I would call the provider because they're right there and they would come down and see this and we would intubate. It's like, it seems scary, but really it's like so commonplace. On the floor, this would be like a rapid response situation.
Yeah.
Like you would overhead page and it would be like a respiratory code and they would come and intubate and then take them to the unit, okay?
Yeah.
So in that situation, yes. That's like just my brain being like, this is normal, you know? I wouldn't like, okay. So I'll let you draw up some rock. So we'll give 50 of rock, Dr. Aaron.
Sure.
Let's do 50 of rock. So there are 100 milligrams per 10 mLs. We're giving 50 milligrams. So how many mLs will you be drawing up?
Say everything.
So it says right here on it. So it's 100 milligrams and 10 mLs.
There's no needle.
And you're giving.
So I want
And you're giving 5 mLs.
Oh, thank you.
So ketamine, we'll do ketamine here or propofol or whatever. So ketamine is 500 milligrams per 10 mLs or 50 milligrams per ml. So we're giving 30 of ketamine, so how much would that be? This dosage is weird, but for this dosage, how much would that be?
We're getting 30 and it's 50
milligrams. We're giving 30 milligrams and this is 50 milligrams per ml.
So like, it's going to be less than 1 ml?
Yeah, it would be like 0.3 ml.
Okay.
Yeah. So obviously this is like a little bit stressful, like sitting here trying to do this med math. And it does not get any better whenever you have somebody.
I'm literally counting on my fingers.
Yes. It doesn't get any better when you have somebody not as nice as Erin at the head of the bed screaming for their sedation and. So, like again. Closed loop communication, being like, I am pulling it up, I am doing this. And then if you are ever unsure dual verify with another nurse beside you, and you should label these syringes, because whenever you give it to the provider, if I hand him this syringe versus that syringe and it's not labeled, who's to know what's in them?
Yeah.
You know what I mean?
Okay.
And do the math for them. So be a little nice to them. So be like, this is 30 per, or this is like 30, this is 30 milligrams of ketamine, it's 50 milligrams per ml. And you can be like, this is 5 mLs. This is 50 of rock. 50 of rock. It's 10 mLs per, or
100 mgs per 10 mLs.
or you could give them a little bit even less and just say 10 milligrams per ml. Do the math a little bit further, just so that they don't have to be there doing anything. Okay, so you would also go and get the intubation kit. So in the intubation kit, you have a handle, different handles, and then you have blades. So it really is provider preference what they use. Usually they'll always use a MAC, which is this. There's different sizes of Macs. So whenever I am trying to distinguish the different kinds of blades, I think of like a Macintosh apple. So apples are curved, the Mac is curved. The other one is a Miller, which is straight. So this I don't really ever see used. In my world, I think that they use them in like pediatrics, but for me, I don't see it very often. And then you also want to ask them what size ET tube, endotracheal tube they want. They come in different sizes. Usually for an adult, it'll be like 7.5 or an 8 size tube. Then you'll get that out for them. And then it comes with the tube, and then it also has a stylet in it, and this helps the provider guide it to where it needs to go. And then it also has a balloon, so I'll show you this before he intubates so that we can see it. So it'll be a little bit bigger than this, but obviously not a good thing to rip out, so that's why we would want to have proper sedation and maybe even restraints on board, because if you rip this out, you probably will damage your vocal cords and not speak again. So important safety issue there. All right, Dr. Aaron, do your thing.
Can we put the head of the bed down and then raise the bed up? Do this lock right now.
Should be.
And then lock it for a second. Put it up.
If you need to drop it fast, you can hold up CPR.
True. You want to bring that head in?
No?
No, it doesn't go up. We'll just,
There you go. It went in here.
Where does it say like the size for
it should be, so like the packages that come on, it'll be labeled on the front.
Oh.
Okay.
So usually you can tell, like that looks like about an 8.
Push
I don't
them.
know if it is or not.
Yeah.
But
Can you
that's
push
just like
them?
for me, like looking at it.
No, you haven't.
Oh yeah, I can back
It will stay on the
Alright. Do we push meds, like physically
Yep,
push
yep,
them?
I'll push I'll be your
Okay.
APP, I'll push them. So it'll tell you here, so 4-0. So for that one, it will be like 8-0 or like
It
7-5.
says it on here. Weird, it's like weird locations
What size
sometimes
is
though.
this? I said it
This
was
is a 6'5".
Ah,
That would be easy.
If I'm
Hopefully these kids.
Can she pull up with this?
If it's 0.3 ml?
yeah, you can. That's a little bit
Okay.
easier. It's more calibrated. It'll be more accurate.
There we go.
It's not like a huge deal, but I just wanted you guys to get the practice of drawing up meds.
Yeah.
Little med math.
My least favorite.
I can draw that up for you while you do this. I want you guys to see this intubation
Okay.
more importantly.
Okay. Hang on.
Have you all ever seen an intubation?
One time.
One
It's
time.
bad.
It was
It
bad.
was bad.
She was like not, the sedation had like not hit. That's why they were like holding her down. She was like screaming.
Probably like because it was somebody like me being stingy with protocol.
I don't know. It was
Yeah.
scary.
Yeah.
Slam it in
There
there.
is a-
They'll be knocked out.
Oh, yeah.
It might be hypertensive as well, I guess. So, the theory of it, I guess, yeah, or, I don't know, you like make this like, do you want me to like walk through this?
Yeah, for sure.
So it's a lot easier to spread their mouth open rather than doing this. You have more force with like this movement. So you like spread open their mouth. It's a really hard. Then you push this in sideways and like sweep their tongue over. Try and wash their teeth, unlike I'm doing right now. So like hitting your teeth all over the place. The tip of this will go like, it's called the vallecula, but it's like right anterior to the epiglottis, and it slides in there, and then you just sort of like, instead of like cranking like this with your arm, it's like a shoulder movement, and you like lift up this way, sort of like toward the ceiling. And then you should be able to see the vocal cords, so I don't see anything.
She might not have any.
Yeah. This is probably going to go in her esophagus. But yeah, then you just sort of like pop it in. People will put it at like 22 at the lip. They always want to know like where is it at the lip.
Yeah, and as so like the roles in an intubation are similar in a code, so you would want somebody recording on drugs if it's needed. And then whenever the provider is intubating, they cannot take their eyes off of what they're doing. So that's why it's really important that you, as the nurse, have all of this there ready for them, and can hand them whatever they need.
Yeah, that's true. In real life, like let's say if I was actually doing it, I would probably have like like one hand doing this part and this hand, and then I would be like tube and not look really, and someone would like hand it to me, and then I would pop it in and then say like stylet, and then they like pull it out while I like hold this here, and someone else will pull it out.
And then you would want to notify respiratory therapy before you're doing this so that they can be in the room to hook the patient up to the ventilator, and go through all of that kind of thing as well. So he mentioned one thing about an esophageal intubation as a potential, what's the word?
Bad thing.
Bad thing.
Yeah, potential bad thing.
So what do we need to assess to ensure that no other potential bad things happen? Like how do you ensure that that tube is in the right place, you as a nurse?
Well, we would also want to know like where.
Yeah, you would want to know where it is so you can write that down and take record of it, but what else? Like what assessments can you do?
Like listen to their stomach, because if there's air going down the esophagus. Like,
Okay, yeah. You would
Or
also
else
want to listen for breath sounds,
Yeah.
also take bilateral breath sounds. You could also just look at them, like clinically look at them, and see if they have any like unilateral chest rise and fall, or if it's bilateral. And then what's the gold standard for ensuring tube placement?
It's an X-ray.
X-ray. So usually if I'm the one recording, I'll take a verbal order, and that X-ray will be here before he's even done, so that they can instantly come in and shoot it and go, and ensure that it's a good place. And then Erin can kind of talk to you a little bit about how
So if
to.
it's not in a good place, do they use like, what?
If it was in the esophagus or something like that, it's not like bad in terms of like damaging to the patient. It's just like now prolonged, like they're not getting air through that whole time. They're not breathing, so I'd have to like take it out and then try again.
Fun story, I've actually had a patient who was anoxic, like he was permanently brain dead because he was, they intubated his esophagus in the field. EMS intubated his esophagus.
Oh my gosh.
So by the time he came to me, he was completely anoxic and brain dead. So, yeah, so in the acute, it's not like it's like you can fix it, but it's definitely something that's like,
Yeah.
time is of the essence for sure.
Do you all know one more way? Right, there's probably other ways too that you can like really quickly assess if it's in at least toward their lungs. You can't verify that it's not wrong, or it's just at least toward their lungs somewhere, and not in the esophagus at least. This one's a bit harder, probably.
Yeah, it's by end-tidal CO2. So this little device here, you'll see respiratory bring it in, they'll hook it up to the end of the tube, and like a bag, like an ambu bag, or the vent, or not really the vent, like an ambu bag. But if it's in the wrong place, this will turn purple or blue, and if it's right, it will turn gold, correct?
I think so, yeah.
So, are the other ones here?
you know, I don't know.
I wanna check out the hallway, see if you can help.
We were like super lost, like
Yeah,
in the lobby.
yeah. So that's another way to check and make sure that it's in the right place very quickly. So, what questions do you guys have?
I don't know.
That's a
It's
lot.
like, how fast is this like supposed to happen?
I mean, within like 5 minutes.
Yeah.
Like literally. It's like pretty commonplace. And I know this seems like a lot and stressful, but this is like a typical night.
Yeah.
Like genuinely it is it's a busy night, but it's a typical night. Like an intubation is not like a huge thing, it's very commonplace.
I see a lot of intubations just because like a lot of meth heads come in. Like,
like
we don't want to
for-
deal with them, just bite
Yeah,
them too.
intubation or protection or whatever they call it.
Oh
Yeah,
yeah.
the ED runs a little differently.
Yeah.
Yeah, so in the CVICU, we're very stingy with like sedatives and stuff like that. Like, so we don't really intubate for that reason very much.
Oh yeah, I've seen that a lot. Just like,
Yeah.
oh, we don't want to deal with them.
Yeah, and then when they come to get them, pull it out and deal with them. So, okay, any other questions? You guys did really good. Was this helpful? Do you feel like you learned
Yeah.
some things? I know it's overwhelming, but again, just like a little bit of exposure is what we're looking for here. We don't expect you guys to be like full-fledged, competent ICU nurses. We just want you to experience some things that you don't get to see very often. Okay. So either of these patients are fair game for your care plan and pathophys, so each of you can submit those to me by tomorrow at midnight.
And we just make one like total, correct?
Yeah. We
No,
do it as
each. Each.
Oh,
Yeah, so you each. That was like some confusion with Christy and I, but it's each.
Okay.
So like we work together and just work
You
separate.
can work together,
Work
but
together, but
yeah,
each
each
turn in our
of
own.
you has to turn in one, and it doesn't have
Next
to.
Friday or tomorrow?
Tomorrow at midnight.
Okay. And just send it to your email.
Just send it to my email. Yep.
Oh, okay.
So we can have like the same diagnoses and like interventions.
If you want
but,
to, if you
just
want to like
different
split it up,
pathways.
I don't care to. But if you want to help each other, you can. Since Christy mentioned that earlier in the week.
Okay.
Alright. Sounds good.
All right. Guys, have a good night. Be safe. If you want
Good job.
to, I would make sure to take that so you have that for your.
Did you hear me laughing on the phone?
Yeah, I
We were
was like-
trying to change the respiratory
I know, I'm
rate
like
back
looking
up.
at it, I was like, okay,
Looked
it's
at us.
12. I'm like, 12. I know, I was like, yeah, like, definitely. And then like 5 seconds later, 42.
Yeah, it was like lagging behind.